Picture this in your mind for a moment. A man, 71 years of age, has been enjoying his retirement for several years now. His mind is still razor sharp, he takes pride in maintaining his own lawn, and he still drives himself across town every Tuesday to join his friends for their regular poker game. His wife, after 2 years of gentle persuasion, finally convinces him to schedule a routine physical examination, something he has been successfully avoiding for the past 24 months. Dr. Mandell greets him, conducts a thorough evaluation, and offers a preliminary assessment. Everything seems to be in good order, he states with reassurance, and then he utters 6 seemingly harmless words that will completely alter the trajectory of this man's life. Let's just run a few tests. Fast forward 3 months, and that same gentleman finds himself in the process of recovering from an invasive procedure that, in retrospect, he never actually required. A procedure performed to address a condition that, had it been left alone, would almost certainly never have caused him any significant problem or impacted his daily existence. Now, instead of enjoying his lawn and his poker games, he is managing a host of complications that have absolutely nothing to do with the original reason he stepped into the doctor's office that day. The life he knew before that appointment, the independence, the routine, the simple pleasures, that version of his existence is now irrevocably gone. This narrative is not an anomaly. It is not a rare occurrence that only happens to a handful of unfortunate individuals. This story is so common, in fact, that it has earned its own designation within the medical literature, and today we are going to examine it with complete honesty and transparency. My name is Dr. Mandell. I am a physician whose practice is devoted to cardiovascular health and the unique challenges that accompany the aging process. My specific area of focus centers on how the body's circulatory system undergoes transformation after the age of 60, and more importantly, what these physiological changes mean for how we approach and make critical medical decisions. Through my years of working closely with adults who have crossed the 60-year threshold, I have observed a pattern that repeats itself with alarming frequency. It goes something like this. Individuals who walked into a routine appointment feeling perfectly healthy, vibrant, and without a single complaint, only to emerge on the other side of the testing process dealing with a medical issue they had never even contemplated before the cascade of examinations began. This recurring pattern has a mechanism. It has a name. And once you truly grasp how it operates, you will never find yourself sitting in a physician's waiting room or examination chair in quite the same way again. Consider this statistic, a number that should genuinely give you pause. Research studies have estimated that somewhere between 15 and 25% of all medical procedures performed annually across the United States are, by medical consensus, unnecessary. But here is the aspect of this data that rarely receives public attention. That percentage does not remain constant across all age groups. In fact, it climbs sharply and significantly after the age of 65. This increase is not because older patients are inherently sicker or more prone to disease. Rather, it is because the delicate balance between risk and benefit undergoes a fundamental and complete transformation once you pass that 65th birthday. And here is the crux of the problem. The modern medical system was never designed, structured, or equipped to accurately calculate that complex equation during a standard 15-minute appointment slot. There is a well-documented phenomenon known in medical circles as the cascade effect. Let me walk you through precisely how it unfolds. It begins with a single routine test that happens to detect a minor, often clinically insignificant abnormality. That small finding triggers the need for a more detailed follow-up imaging scan. The scan, in turn, produces a recommendation for a biopsy to investigate further. The biopsy then leads to a full-blown surgical procedure, and that procedure unfortunately results in a complication. The end result is that a person who entered the medical system feeling completely well is now navigating a complex medical situation they did not have before they ever agreed to that very first screening test. The cascade does not originate with the surgery itself. It originates with that initial, seemingly harmless test. And that is precisely the central theme of our discussion today. Over the course of this presentation, I am going to guide you through 5 specific medical checkups and screening tests that I personally would strongly encourage you to reconsider after you have reached the age of 65. Please do not misunderstand my intent. This is not an indictment of medicine as a flawed or broken system. This is simply an acknowledgement that after age 65, the risk to benefit calculation shifts dramatically, and very few healthcare providers are having this open, candid conversation with their patients. I am going to explain exactly why that equation changes, share with you real world examples of what I have witnessed happen to actual patients, and most importantly, I will equip you with a specific set of questions at the conclusion of this video that have the power to fundamentally transform the dynamics of your next medical appointment. I urge you to stay with me through all 5 items on this list. Number 3, in particular, tends to surprise people the most because it involves a test that on the surface sounds like nothing more than pure, unassailable common sense. And number 1, the final entry on our list, is the checkup that almost nobody is currently questioning, despite the fact that the underlying data supporting it is more concerning and troubling than almost anything else we will cover today. Before we dive into the details, I would like to invite you to participate. Please take a moment to leave your city or state in the comments section right now. I personally read every single comment that comes through, and I genuinely value knowing who is taking the time to watch this content. It means a great deal to me to see the incredible community that has grown around this channel, and your participation helps me understand who I am speaking to. But before we proceed to the list, there is one foundational concept that you absolutely need to understand, because without it, nothing else I share with you today will fully resonate or make complete sense. I refer to this concept as the longevity lens. Here is how it works in practical terms. When you are 50 years old, routine screening is often one of the most valuable investments you can make in your long-term health. You have the opportunity to identify a potential problem in its earliest stages, intervene with treatment, and potentially gain 30 or more additional healthy, productive years of life. The equation is relatively straightforward and favorable. The investment of time, effort, and exposure to procedural risk pays off handsomely in the long run. However, after the age of 65, 3 critical factors fundamentally alter that equation. First, many of the conditions that routine screening identifies in adults over 65 will never actually progress to the point of causing harm. These conditions tend to grow at an extremely slow pace, they produce no noticeable symptoms, and in a significant percentage of cases, you will outlive them entirely without ever experiencing a single adverse effect. But here is the challenge. Once an abnormal result appears on a medical report, the system of medicine does not possess a simple "leave it alone" button. It has a treatment button, and that button is almost invariably pressed, often without adequate consideration of whether intervention is truly necessary. Second, your body's physiological tolerance for medical intervention at 65 is simply not what it was at 50. A surgical procedure that a 58-year-old might recover from in a matter of 2 weeks can translate into months of difficult recovery for a 73-year-old, often accompanied by complications, a significant loss of independence, and a post-procedure quality of life that may bear little resemblance to what existed before. Third, we must always account for the cascade effect, that chain reaction where one test leads to an abnormality, which leads to another test, which leads to a procedure, all beginning from a starting point where you are feeling perfectly fine. Keep this longevity lens firmly in mind as we work our way through every single item on this list. All right, let us now dive into the substance, beginning with number 5 on our countdown. Checkup number 5 is the routine PSA screening test. Specifically, I am referring to prostate testing after the age of 70 in low-risk men who are experiencing no symptoms whatsoever. This is a topic that requires precision and nuance, because it is very easy to misinterpret what I am saying. I am not suggesting that prostate cancer is not a serious disease. I am not claiming that PSA testing has no value or utility in any context. What I am saying is that for men over the age of 70 who have no symptoms, no family history of the disease, and no prior urological concerns, the data on routine PSA testing reveals a story that most men have never been told when sitting in their doctor's office. Here is the core issue at play. A PSA test has the capacity to detect a prostate cancer that is, from a biological standpoint, progressing at an almost imperceptibly slow rate. We are talking about a tumor that grows so gradually that if left entirely alone, it would never metastasize, never produce symptoms, and in a 71-year-old man, it would almost certainly never shorten his lifespan. He would live with it peacefully, not die from it prematurely. But the instant that test result comes back with an elevated number, the machinery of medicine does not wait. Biopsies are ordered without delay, specialists are consulted, and a range of treatment options are presented. For a 71-year-old man who is otherwise healthy, treatment for low-grade prostate cancer can mean radiation therapy, hormone therapy, or surgical removal, each of which carries real and substantial risks to bowel function, sexual function, energy levels, and overall quality of life. The American Cancer Society has updated its official guidance precisely because of this issue. For men with a life expectancy of less than 10 years, or for older men at average risk who have no symptoms, the risks associated with finding and treating a slow-growing cancer frequently outweigh the potential benefits that might be achieved. I want to share with you the story of a patient I will call Raymond. Raymond is 74 years old, a retired electrician from Tulsa, Oklahoma. He was physically fit, remained active, had absolutely no family history of prostate cancer, and reported no urinary symptoms whatsoever. During his annual physical, his routine PSA test came back with a slight elevation. A subsequent biopsy confirmed the presence of a low-grade, slow-growing prostate cancer with a Gleason score of 6, which in medical terminology means it is about as indolent and slow-moving as prostate cancer can possibly be. His urologist recommended a course of radiation therapy. Raymond, trusting his physician's recommendation, proceeded with the treatment. Within 8 months, he found himself dealing with chronic fatigue that disrupted his mornings, urinary urgency that fundamentally changed how he navigated his daily life, and an overall quality of life that had declined in ways he had never anticipated or been warned about. When he sat down with Dr. Mandell 1 year after completing treatment, the words he used were striking. He said, "I felt better before they found it than I do now that they fixed it." That sentiment is not rare. It appears throughout the medical literature with a consistency that should give every man over 70 considerable pause before automatically agreeing to a routine PSA test. So, what should you do instead of automatically proceeding with screening? If you are experiencing urinary symptoms such as hesitation, changes in urinary flow, or increased frequency of urination at night, you should absolutely have a conversation with your doctor. Those symptoms are meaningful and deserve attention. If you have a strong family history of prostate cancer, that also changes the equation and may warrant more aggressive monitoring. However, if you are over 70, have no symptoms, and are considered average risk, the conversation with your physician should not start with, "Should we screen?" The more appropriate conversation should be, "What would we actually do if we found something?" And, "Would that treatment improve my life more than carefully monitoring the condition over time?" That single question alone often changes everything about the decision-making process. Now, let us move on to checkup number 4. Checkup number 4 involves routine bone density DEXA screening, followed by the automatic initiation of long-term medication. Before anyone jumps to conclusions or misunderstands this section, I want to be clear. Osteoporosis is a real and serious condition. Falls can be devastating for older adults, leading to fractures that significantly impact mobility and independence. I want to be precise here because there is a profound difference between questioning a screening test and questioning the automatic treatment pathway that so often follows that test. A DEXA scan measures bone mineral density. If the results indicate low bone density, many physicians will immediately prescribe a class of medications known as bisphosphonates, which include well-known drugs like Fosamax, Boniva, and Actonil. You have likely encountered these names in television advertisements or magazine promotions. The message delivered is simple and compelling. Low bone density equals medication, and medication equals protection against fractures. But here is what that message frequently leaves out of the conversation. Long-term bisphosphonate use, particularly when continued beyond 5 years, has been associated with a rare but serious condition known as atypical femoral fractures. These are stress fractures of the thigh bone, the very bone that the treatment is intended to strengthen and protect. These fractures can be severe, often require surgical intervention, and in some cases they create more disability than the fracture they were originally prescribed to prevent. There is also a condition called osteonecrosis of the jaw, which involves the deterioration of jawbone tissue. This condition can be painful, difficult to heal, and in some cases it is triggered by the very medication that was intended to strengthen the skeletal system. Meanwhile, and this is a part of the discussion that should be included in every conversation about bone health, the single most effective intervention for reducing fractures in adults over 65 is not necessarily medication at all. It is fall prevention and balance training. Research on Tai Chi, for example, has demonstrated that it can reduce fall risk by nearly 50%. Other effective measures include removing tripping hazards from the home, installing grab bars in bathrooms, reviewing current medications that may cause dizziness, and having your vision checked every year. These interventions often reduce actual fracture risk more effectively than many medications, and they accomplish this without any of the medication-related side effects. Let me tell you about Gloria. Gloria is 72 years old, a retired elementary school teacher from Phoenix, Arizona. Following her annual physical, she underwent a DEXA scan and was informed that her bone density was below normal for her age. Her physician prescribed a bisphosphonate on that very same day and advised her to continue taking it indefinitely. Gloria came to see Dr. Mandell 3 years later after developing persistent aching in her thigh. Further evaluation revealed an early atypical stress fracture. She had never experienced a fall. She had no history of fractures, and she was taking medication intended to prevent fractures, yet her bone was reacting adversely to that very treatment. So what should you ask before automatically starting medication? Ask your doctor, what is my actual fracture risk based on my complete health profile, not just this single scan result? And can we compare the potential benefits of medication with the benefits of a structured fall prevention program? That question is neither difficult nor confrontational. Any good physician should welcome it and be prepared to have that discussion with you. Now, let us proceed to checkup number 3. Checkup number 3 is routine cardiac stress testing in people who are completely without symptoms. This is the one that surprises a great many people because it sounds incredibly responsible and proactive. Your doctor says, "You are 68 years old. Let's just make sure your heart is functioning properly." You get on a treadmill, or they administer a medication that temporarily stresses your heart while they monitor its response. What could possibly be wrong with that approach? Here's the problem that almost no one discusses in the examination room. Cardiac stress tests performed on people without symptoms, no chest pain, no shortness of breath, no dizziness during exertion, can have false positive rates approaching 40% in certain populations. What that means is that in nearly half of those cases, the test identifies an abnormality even though the heart is actually functioning normally. But medicine cannot simply ignore an abnormal result. That false alarm often pushes you directly into the next stage of the cascade, which is cardiac catheterization. During this procedure, a thin tube is threaded through your blood vessels, usually through the wrist or groin, and guided directly into the heart. The risks associated with this procedure include bleeding, blood vessel damage, heart rhythm disturbances, and in rare cases, the catheterization itself can trigger the very cardiac event that the screening was intended to prevent. And if the catheterization discovers a partial blockage, which is extremely common among adults over 65, including many who may live for decades without a single cardiac event, you may be advised to receive a stent. Now, this is the part I really want you to hear and absorb. Multiple major clinical trials, including the ischemia trial, which is one of the largest studies of its kind ever conducted, found that placing stents in patients with stable coronary artery disease did not reduce heart attacks or extend life when compared with medication and lifestyle management alone. The stent did not outperform a 30-minute daily walk, combined with appropriate medical therapy. However, it carried all of the procedural risks and often required years of blood-thinning medication afterward. So, the cascade often looks like this. You are feeling fine, you undergo a routine stress test, you receive a false positive result, you proceed to cardiac catheterization, you receive a stent, you are placed on blood thinners, you undergo ongoing monitoring, and yet there is no statistically significant improvement in your long-term outcomes. That is the complete picture, and it all began because someone in the medical system said, "Let's just check." If you are finding this information valuable and insightful, I would appreciate it if you would type the number 3 in the comments section. It is a simple way to let me know you are following along, and it genuinely helps this channel reach more people who may benefit from this information. So what should you do instead of automatically agreeing to a stress test? If you have no chest pain, no unexplained shortness of breath, and no dizziness during physical activity, the conversation with your doctor should not primarily focus on stress testing. It should focus on optimizing the factors that actually drive cardiovascular risk: blood pressure, cholesterol levels, blood sugar control, physical activity, and sleep quality. That is where the greatest cardiovascular gains occur after the age of 65. And none of those improvements require a catheterization to achieve. Now let us move to checkup number 2. Checkup number 2 is routine carotid artery ultrasound in asymptomatic patients. Almost nobody is talking about this one, and based on what the evidence shows, that silence may be one of the most significant oversights in routine senior healthcare today. A carotid artery ultrasound examines the large blood vessels in the neck that carry blood to the brain. The concept sounds perfectly logical on the surface. Identify a blockage before it causes a stroke, surgically remove the blockage, and the problem is solved. But the reality is considerably more complicated, and for people without symptoms, potentially more dangerous than it initially sounds. Here is the fact that changes everything. The surgical procedure commonly used to treat carotid artery narrowing, known as a carotid endarterectomy, carries approximately a 2 to 3% risk of causing a stroke during or immediately after the procedure. In older adults with additional health conditions, that risk may be even higher. The United States Preventive Services Task Force, the organization widely regarded as the gold standard for screening recommendations in the United States, specifically advises against routine carotid artery ultrasound screening in adults who have no symptoms. Their conclusion is straightforward and evidence-based. For asymptomatic individuals, the risks associated with intervention generally outweigh the potential benefits. Here is why this recommendation exists. A substantial proportion of adults over 65 have some degree of carotid artery narrowing. In many cases, that narrowing has existed for years. It remains stable, it remains silent, and it never causes any problems whatsoever. But when routine screening detects it, a well-intentioned specialist may recommend fixing it. The problem is that surgery performed on a blockage that was never causing symptoms can dislodge a small fragment of plaque. That fragment may travel directly to the brain. The intervention ends up causing the very outcome it was intended to prevent. So what should you do instead? If you have no neurological symptoms, no sudden vision changes, no facial drooping, no arm weakness, no brief episodes of confusion, and no episodes of slurred speech, routine carotid artery screening is generally not recommended and should not be your primary focus. Your attention should be directed toward managing the factors that genuinely increase stroke risk: blood pressure, which is the most important one, blood sugar control, atrial fibrillation if it applies to you, and maintaining consistent physical activity. However, if you experience any of the symptoms I just mentioned, even briefly, even if they disappear completely within minutes, That changes the situation entirely. Seek medical evaluation immediately. At that point, we are no longer discussing routine screening. We are talking about your body sending a warning signal that deserves urgent and prompt attention. Now we arrive at checkup number one, the final and most important item on our list. Checkup number one is routine colonoscopy after the age of 75 in low risk asymptomatic adults. This is the one that most people have never heard challenged, because colonoscopies have been so thoroughly and broadly endorsed for so many years that questioning them in the appropriate context can feel almost counterintuitive, even sacrilegious. But the data for adults over 75, specifically those with no symptoms, previous clean colonoscopies, and no family history of colon cancer, tells a different story than most people have heard. The United States Preventive Services Task Force explicitly recommends against routine colonoscopy screening in average risk adults over the age of 75. Their reasoning is not vague or ambiguous. The risks begin to outweigh the benefits, and those risks become very real when you understand what can go wrong. A bowel perforation, which is a literal tear in the wall of the colon, occurs in approximately 1 out of every 500 colonoscopies. For a younger adult, that may be a manageable surgical complication. For a 77-year-old, it can mean emergency surgery, a colostomy, prolonged hospitalization, and a recovery process that permanently changes independence and quality of life. And that is not even including the preparation itself. The bowel cleansing solution required before the procedure can cause dangerous dehydration, electrolyte imbalances, and significant cardiovascular stress in older adults. There is also the risk associated with sedation, which increases with age and can have unpredictable effects. And then we return once again to the longevity lens. The colon cancers most likely to be discovered in asymptomatic adults over 75 tend to grow slowly, slowly enough that in many cases they would never cause meaningful problems during that individual's remaining lifetime. I want to tell you about Margaret. Margaret is 78 years old, a retired school teacher from rural Ohio. She had undergone 2 colonoscopies during her 50s and 60s, both completely normal, with no polyps detected, no family history of colon cancer, and no symptoms of any kind. Her new primary care physician reviewed her chart and told her she was due for another screening. Margaret asked questions, seeking clarification, but she was reassured that it was simply routine, so she agreed to proceed. The preparation affected her severely. By the following morning, she was confused, weak, and barely able to stand. Her daughter, concerned by her mother's condition, brought her to the emergency department before she ever reached the scheduled procedure. Her electrolyte levels were critically low, and her heart was under significant strain from dehydration. She spent 5 days in the hospital recovering. She never actually underwent the colonoscopy, and the findings from those 5 days revealed that her heart and kidneys had been stressed by a process intended to screen for something she almost certainly did not have, and even if she had it, would most likely have outlived. When Margaret called Dr. Mandell after being discharged, she said, "I felt better when I was overdue for that test than I did after trying to take it." So, what should you do instead of automatically proceeding with a colonoscopy? Ask your doctor about non-invasive stool-based screening options, such as Cologuard or an annual FIT test. These tests can identify meaningful warning signs without exposing you to the procedural risks associated with a full colonoscopy. And if you do have symptoms, such as blood in the stool, unexplained changes in bowel habits, persistent abdominal pain, or unexplained weight loss, that changes the equation completely. Those symptoms deserve thorough medical evaluation regardless of age. Now let us move to the practical advice I promised you earlier. Every time a doctor recommends a screening test, especially if you are over 65 and feeling well, I want you to have 5 specific questions ready. Write them down, save them in your phone, bring them to every appointment. Question number 1. What is the false positive rate of this test in people my age? This question tells you how likely the test is to send you into a series of follow-up procedures even when nothing is actually wrong. Question number 2. If this test finds something, what are the realistic treatment options for someone my age and health status? Do not let the discussion stop at, "We found something." Push the conversation one step further to, "And then what?" Question number 3. What is the procedural risk of the treatment we would most likely pursue? Every procedure carries some degree of risk, and you deserve to understand that risk before the procedure, not after it. Question number 4. What happens if we monitor this instead of treating it immediately? For many conditions identified in older adults, watchful waiting is a legitimate and often superior approach. That is not giving up. That is making decisions based on appropriate risk-benefit analysis. Question number 5. What is the most effective non-invasive approach for this condition? Because as you have seen today, whether we are discussing bone health, heart health, or stroke prevention, lifestyle changes and appropriate medical management frequently outperform invasive procedures while carrying only a fraction of the risk. Any physician who genuinely has your best interests at heart will welcome these questions. They will not make you feel difficult or troublesome for asking them. And if a doctor dismisses those questions or makes you feel like a problem patient simply because you asked them, that is important information about whether that physician is the right fit for you and your healthcare needs. Here's what I want you to do starting today. Before your next appointment, whether it is next week or 3 months from now, write those 5 questions on a note card or save them in the Notes application on your phone. Do it today. Bring that card with you when you go. You may not need all 5 questions, you may only use one of them, but having them available changes how you enter that room, and how you enter that room can change the decisions made about your health. Try this for the next 30 days. One appointment, those 5 questions, and I can tell you what you will notice. By the end of those 30 days, you will feel like a different kind of patient. Not a difficult patient, but a protected patient. Someone who understands why tests are being ordered, what the follow-up procedures mean, and what questions should be asked before the cascade begins. There is probably someone in your life, a spouse, a sibling, an adult child, or someone helping care for aging parents who needs to hear what we discussed today before their next annual physical examination. You do not have to explain it all yourself. You can simply send them this video. If this conversation has changed the way you think about routine medical care after the age of 65, I would invite you to subscribe to this channel. Next week, Dr. Mandell will be discussing something that connects directly to everything we talked about today. Specific medications that are routinely prescribed to adults over 65, but carry a completely different risk profile at that age than they do at 50. And the questions you should ask your pharmacist before refilling them. If you take more than 2 daily medications, that video was made specifically for you. Please leave a comment below. Have you ever had a routine medical test lead somewhere you never expected? Your experience in the comment section may be exactly what someone else needs to read before walking into their next appointment. Take care of yourselves and stay informed. I'm Dr. Mandell, and I will see you next week.